everyone. Thank you for joining us today for the Congenital Myopathies Clinical Presentation, Diagnosis and Management Grand Round webinar. And to introduce our presenters today, we have Dr. Susan Iannacone, Dr. Caitlin Batley, and Dr. Gonzalez from UT Southwestern Medical Center. And I will hand it off to Dr. Gonzalez to kick us off.
Hello, good afternoon. We're very happy to be with all of you and talk about congenital myopathies. We're going to be reviewing a few things. You can see here the objectives. We're going to be talking about the signs and symptoms of congenital myopathies. We're also going to review the practice guidelines for the management of patients with congenital myopathies. We're going to also discuss clinical trial opportunities, and at the end, we're also going to provide with some additional tools and resources for physicians as well as patients. So this is going to be the overall agenda for this afternoon. We're going to first talk about the overview, classification, clinical presentation, and pathophysiology, and then I will hand over to Dr. Iannacone to tell us more about the standard of care and management, and Dr. Batley will tell us more about clinical research and resources. In general, when we think about congenital myopathies, is a group of hereditary rare neuromuscular disorders that are going to be characterized mainly for muscle weakness and hypotonia. However, we do know that the muscle weakness and hypotonia are non-specific for congenital myopathies. These group of disorders are very heterogeneous, not just clinically, but also when we think about the histopathology and the genetics. Some examples when we think about same variants of the same gene that are going to cause different muscle pathology, or we can also see that same genetic variants can actually have different features within the same family. And it has also been seen that even in the same individual over time, we can see different features. So this makes this group of disorders very fascinating. As I already mentioned, clinically, the common feature is going to be weakness and hypotonia. Historically, this group of disorders has been classified based on the morphological features that were seen in muscle biopsy. We're going to review these later on during the presentation. The prevalence is about 1 in 26,000 cases. And from all the cases of neonatal hypotonia, congenital myopathies are going to be 14% of these. The typical onset usually is at birth or infancy. And what characterizes this group of disorders is the very slow progression and stable clinical course. Overall, the life expectancy can vary and is going to depend on the type of congenital myopathy as well as the severity of the disease. But when we think about the birth onset forms, usually these kind of patients will have shorter life expectancy. They can live less than 1 year. And one example would be the X-linked central nuclear types, as well as Memaline myopathy. In contrast, the adolescent and adult onset forms can have a normal life expectancy, and they can still be ambulatory by the age of 50. I think it's also very important to talk a little bit about the myopathological history. It was back in 1958 when Dr. Douglas Rye first described these rod-like fragments in a muscle biopsy of a 3-year-old boy. And this finding went through a second opinion, and it was thought that this was actually a processing artifact. So the work of Dr. Rye was never published. And actually, the first description of these rod-like fragments was done in 1963 by Dr. Cheyenne and the collaborators, and they actually found the same rod-like fragments. Later on, when this same 3-year-old boy was reevaluated as an adult, it was actually found that he had a mutation on the ACTA1 gene. So now we know that actually the first one that described this pathological feature was Dr. Rai. We can split the era in three groups: the nosographic evolution of the congenital myopathies, when they describe these classical groups: central core myopathy, nemaline myopathy, and central nuclear myopathy. From 1970 up to the 90s, these started to expand. The spectrum of disorders, clinically, myopathological, and genetically, was broader. And then from 1990, then we got to the genetic era, when we see that actually the congenital myopathies are going to be named after the gene that caused the disease, and we might or not see the disease-specific pathological lesion. Although this, again, is a historical classification, I think it's very important to review it. We're going to break it down in 5 groups, and we're going to mention a little bit of the features when we talk about the specific congenital myopathies. We have on the left, we can see the nemaline rod myopathy. As the name says, the hallmark is going to be these nemaline rods. Now, these rod-like inclusions are going to be made up of alpha-actinin and filaments within the muscle fiber. And you can see these darker aggregates on the Gomori triform stain. The second group are going to be the core myopathies that include central core and multi-mini core, the main ones. We do have the central, for the core myopathies, I'm going to just briefly mention these pale central areas are going to be the areas of decreased oxidative activity. In the middle, you will see the central nuclear myopathies that will be characterized by these, the location or centrally located nuclei within the muscle fiber. These will include the myotubular myopathy, as well as the central nuclear myopathy. And then we have the myosin storage myopathy and the congenital fiber type disproportion. The hallmark for myosin storage myopathy is usually the hyaline bodies. It is not what we are depicting on this picture, but what we know, because this is a very heterogeneous disease, is that myosin storage myopathy can also present with cores and multi-mini cores, which is exactly what we're seeing on this muscle biopsy. Then we have the genetic approach. And as the molecular testing evolves, now we have a classification that is based on the gene that is causing the disease. Example, mutations on the RYR1 gene will be called RYR1 related myopathy. Even within the genetic classification, we can see that there's going to be a lot of overlapping in between the genes that cause the disease and the clinical features. We can see on this picture on the left, the main group of congenital myopathies, as well as the genes that are associated with these disorders. And we can see the great overlap in between each group. Overall, the inheritance of these disorders can range from autosomal dominant, autosomal recessive, and X-linked. Now that we have reviewed the overall or the general overview about congenital myopathies, let's move on about the clinical presentation. There are going to be some common clinical features that we will see on these patients. In general, the phenotype is going to vary significantly. However, the muscle weakness is going to be the main common feature. They can also present with hypotonia, and we can see these in at birth and infants with this frog leg position. We can also see decreased muscle bulk. We can see low reflexes, and we can also notice these myopathic faces that we can actually see on the picture of the patient on the right. That is going to be a facial appearance due to the weakness of the muscles of the face. And as you can see here, you can see bilateral ptosis. Patients will have difficulty with eye closure completely. They can have temporal wasting. You will see deep sunken cheeks. You can see also this upper tented lip or a transverse smile, again, due to the weakness of the muscles of the face, as well as micrognathia, high arch palate, and crowding of the teeth. Generally, intelligence is normal and sensation is intact. The only situation when we can see intelligence affected in these patients, it would be if there was a history of hypoxic injury at birth. And again, this would not be associated with congenital myopathy. Let's talk more about the specific groups of congenital myopathies. Let's start with the nemaline myopathies. Overall, they can range from milder to severe forms. The mild forms are the more common ones, and clinically they can have weakness on the extremities, trunk, muscles of the face. And again, as we mentioned, the progression of the disease will be slow and stable. Now, the neonatal form, it will be up to 16% of all cases. And usually these patients will present with severe hypotonia, difficulty feeding, swallowing, and so on. When we think about the genes that are associated with nemaline myopathies, there are up to 14 genes involved. And most of these genes are going to be the ones that encode proteins associated with thin filaments in the sarcomeres. ACTA1 and nebulin will be more than 80%, or will give to more than 80% of all the cases of nemaline myopathies. We're also highlighting here mutations on the KLHL40 gene. We're going to be talking a little bit about what makes also this type of myopathy a little bit different. But then you'll see on the right the muscle biopsy. The features that we will see, as I mentioned earlier on, will be the presence of these rod-like structures that are called nemaline bodies. On the upper right corner, you will see the Gomori trichome technique, and you see staining red these aggregates that will be made up again of alpha-actinine and the thin filaments from the muscle fiber. On the right lower corner, you will see the electron microscopy, and you can see more clearly these rod-like structures. Nebulin-related myopathy is caused by Neb that encodes nebulin. Is a very large protein and is fundamental for the sarcomere structure. Most of the cases are going to be due to autosomal recessive mutations, and the clinical presentation is going to vary. From severe fetal akinesia, the neonatal to infantile onset, which is the most common one, and the adult onset myopathy. These patients can have neck flexor and facial muscle weakness, proximal muscle weakness that will present early on, and then the distal muscles will be affected later on the disease. Typically, respiratory involvement is very common, and cardiomyopathy is rare. ACTA-related myopathy is the other causative gene for nemaline myopathies. This is going to encode the skeletal muscle alpha-actin-1, which is the main actin isoform in the adult skeletal muscle. Up to 90% of the cases are going to be due to dominant variants and 10% to recessive variants. It presents very similar to nebulin-related myopathy, and the main difference is going to be that patients with ACTA1 related myopathy are going to have more gastrointestinal complications, and they will require a gastrostomy, a jejujostomy, or some type of feeding support. Typically, they don't have cardiac involvement, and they would not also have either ptosis or ophthalmoplegia. Up to a third of the patients will have a severe phenotype, and unfortunately um, will pass before turning 1 year of age. And the other third of the patients will typically start around the prenatal time. If we were to do any imaging on MRI, we will see that some of the muscles that are affected proximally will be the gluteus maximus. Distally, we can see that the TA is also affected. And we will talk a little bit more about patterns, recognition patterns for imaging in these disorders. KLHL4 derogated myopathy is typically a severe myopathy. However, there has been a few cases of milder forms, like the one we are presenting here. This is a 5-year-old boy that initially presented with hypotonia at birth. He did have motor delays throughout childhood and had some feeding difficulties. You'll see in the video this bilateral wing scapula, these scoliosis and asymmetry of the back. Very thin boy, and you can see that he had a G-tube previously. Now he's doing a little bit better, but this is just to show some examples of how the disorder can vary phenotypically. Now I'm going to talk about the core myopathies. There are up to 15 non-causative genes. The most common ones are going to be the ones related to RYR1 and selenon. Now, the typical pathology that we will see in the muscle biopsy will be these pores that will be located in the central portion of the muscle fiber, and this would be due to the lack of oxidative enzymes. The classification within this, based on the muscle biopsy features, would be the central core that usually is in RYR1, mini core, and multi-mini core, which is typically associated with selenon variants. And you can see these smaller areas, tail areas within the muscle fiber. The most common congenital myopathy is RYR1. RYR1 encodes the ryanodine receptor isoform 1, and is the one that is going to be in charge of facilitate the release of calcium, maintain the homeostasis within the fiber. Usually recessive mutations are going to have a severe phenotype, and the pathological phenotypes are many, ranging from central core, multi-mini core, malignant hyperthermia, congenital fiber type disproportion, and the other ones that we have listed here. And this would be the group of patients that will have a higher risk of malignant hyperthermia. Again, the progression of the disease is very slow, and these patients can have, especially the ones with central core disease, hip dislocation, scoliosis, and joint contractures. Again, if we were to do imaging on these patients, we will see some proximal muscles that will be affected, such as the adductor magnus. Distally, we will see also the soleus is affected, but typically the rectus femoris, gracilis, adductor, and the TA will be relatively spare. Within this core myopathy, we also have the selenon-related myopathy. This is going to encode the selenoprotein N, which also participates in calcium homeostasis. Typically, the onset is in the neonatal period to early childhood. They can present with proximal weakness, axial weakness, ptosis, ophthalmoplegia, and one of the features in this group is the rigid spine. Patients will have a lot of difficulty extending or flexing the neck due to the contractures that they will present. And typically, a respiratory failure is very common around 10 years of age in more than 80% of the cases. The third group of myopathies are going to be the central nuclear myopathies. We can divide these in the central nuclear and X-linked myotubular myopathy. For the X-linked form, mainly is going to be due to mutations on the MTM1 gene, and for the central nuclear myopathy, dynamin 2. Now, the name myotubular was initially given because on the muscle biopsy, it was seen that the muscle fibrils resemble fetal myotubes. And it was thought that there was some sort of arrest during the development of the muscle fibers, but when they evaluated muscle biopsies from patients with X-linked myotubular myopathy, they actually didn't see the same features. Instead, they saw these centrally located nuclei. So then the term myotubular myopathy is used specifically when we talk about mutations related to MTM1. But as a group, they are called central nuclear myopathies. We're going to just briefly mention about X-linked myotubular myopathy, which is the severe phenotype within this group. Again, it is caused by changes on the MTM1 gene that encodes for the myotubular protein. This protein is the one that is going to regulate the pathway, the endosomal lysosomal pathway, and the membrane trafficking. As I mentioned, these patients have a severe gene phenotype. They have severe weakness and hypotonia, as well as severe respiratory failure, needing for a feeding tube, and they can have ophthalmoplegia and ptosis, as we can see in the video on the right. You can see this patient has complete inability to move the eyes. You can see the myopathic phases. And as you will see in a little bit, he is trach and G-tube dependent. The last group that we're going to talk about is congenital fiber type disproportion. There are up to 8 genes that are associated with this group. And what we will see on the muscle biopsy will be this difference in the caliber of the fibers in between the type 1 that are the slow ones and the type 2 that are the fast ones. Usually the type 1 in this kind of disorders will be smaller. Most of the patients affected with this, they will have hypotonia, and it can range from mild to severe generalized weakness within the first year of life. Now that we have briefly talked about the main classification for congenital myopathies, we can actually group all the pathophysiology in 5 pathways that can be affected or that has been proposed and can explain these abnormalities. One of those would be changes in the sarcolemma and the remodeling of the membrane that will affect the extension and contraction coupling. One example would be the mutations associated with RYR1. We can also have defects or abnormalities in the mitochondria function and the distribution. And again, we can also see these on RYR1, on mutations associated with MTM1 and selenoprotein. And we can see that when the filaments of the sarcomere are affected, as it is showed on number 3, we can also have another group of disorders. And lastly, number 4 and number 5, any sort of abnormality in the autophagy and atrophy of the muscle fiber can also lead to congenital myopathies. The diagnosis is going to be, or the suspicion is going to be clinical. And this is going to based on the main characteristic of weakness. And then we're going to use other tools to confirm the diagnosis. As I mentioned earlier, now that we have genetic testing, we typically will use that after we have the suspicion for after our clinical evaluation. And if after exhausting genetic testing, we do not have an etiology, then moving forward with either imaging or muscle biopsy will be the next steps. Compared to other group of disorders, the serum CK and EMG nerve conduction studies are either normal. It would not help us confirm the diagnosis, but can help us rule out other differentials in case, again, that after doing a very thorough workup, we still don't have an etiology. This is overall the patterns that we can see on muscle imaging. We will break it down in if the patients have involvement of the proximal muscles or if the predominance of the weakness is just on the lower leg. We can start with the upper left. If the patient has more predominant leg involvement or distally, then if it is diffuse, we will think about TMP2. If the posterior compartment of the leg is the one that is more affected, then we can think about dynamine defects. If the anterior compartment is the one that is more affected, we can either think about ACTA, nebulin, NYH7. And the other group that we see on the bottom would be when we do have proximal involvement, and depending if the TA is involved or not, then we can think about specific mutations. A couple of examples briefly. This is on the left, we'll see the CT, and on the right, the MRI of a patient with RYR1 related myopathy, where we can see that the anterior compartment is involved. On the pelvis, you can see the gluteus maximus is involved. And on the thigh, we can see the sartorius, the Dr. Magnus, the gracilis are also involved, as well as more distally, we can see the soleus and the peroneal muscles involved. In contrast, when we see image of patients with mutations related to selenon, the posterior compartment is involved. You will see marked fatty degeneration in the paraspinal, intercostal, and gluteal muscles. And when we take a look on the muscle imaging of the thigh, you will see that the sartorius and the hamstring are more affected. And usually on the lower leg, the medial and lateral gastrocnemius will be also affected. To summarize, we should also think about differential diagnosis when we see patients with muscle weakness and hypotonia. Again, because there's significant clinical overlap, some of the differential diagnoses that we should think of include congenital muscular dystrophies, congenital myotonic dystrophy, congenital myasthenic syndromes, metabolic myopathies. We should never forget SMA, as well as other syndromic features. And again, very important to highlight that if you see any of these signs or features, you should suspect an alternate diagnosis, such as upper motor neuron signs, CNS abnormalities, tongue fasciculations, think, among other things, SMA, extreme joint laxity, metabolic abnormalities, and if the CK is highly elevated. There are some features that are going to be pointing us towards some specific group of genetic abnormalities in the newborn and infant, as well as in older patients. But I'm going to just highlight a couple of them. In the newborn and infant, we can see that mutations associated with RYR1, they can have more orthopedic abnormalities. They can also have hyperlaxity, and we should take that into account because it can share some features of collagenopathies. I also want to highlight patients with ophthalmoplegia and ptosis, which should think about myotubular myopathy. RYR1 can also have these type of abnormalities. And for older patients, I'm going to just highlight here on the left mutations associated with selenon 10% with severe scoliosis and rigid spine. On the right, you can see that RYR1 is highly associated with malignant hyperthermia compared to the other subgroup of disorders. And now I'm gonna let Dr. Anacon tell us more about standard of care.
Thank you, Zuri. That was wonderful. So I will review the standard of care guidelines. Many of these have been published. And as Zuri has mentioned, there are multiple system involvement in these patients. And so the management and care must be multidisciplinary, with the patient at the center of this care program. Generally, the pediatric neurologist is the one who oversees all the subspecialty care. This is for two reasons, I think. One is it's usually a pediatric neurologist who makes the diagnosis. And secondly, it is the pediatric neurologist who knows the most about the underlying pathophysiology and the natural history of these diseases. So we have four categories here. Under orthopedics, we include PT and OT, which are generally used to manage symptoms. And then we have gastroenterology and nutrition, because many of the patients have difficulty swallowing and difficulty maintaining body weight. Cardiology is included generally as part of the screening process, and we will come back to this in a minute. And then pulmonology, probably of all the subspecialties, is the most important because this group of patients has a very high incidence of restrictive lung disease that is frequently progressive. Next. So under neurologic care, again, it is usually the pediatric neurologist who coordinates care for all the subspecialties. Patients are seen regularly, usually every 6 months, depending on the diagnosis and the age. For younger children, we want to see them more often because we're monitoring growth and development and respiratory function. We also want to look at mental health care and pain management as the patients get older. Central nervous system is rarely involved, as Zuri's already mentioned, although certain genes, such as the dynamin gene, might be affected with mild cognitive impairment. Next. So for cardiology involvement, while cardiomyopathy is rare with these disorders, it happens often enough that these patients should be screened periodically for cardiac involvement. These genes are present in cardiac muscle, and so most of these patients are at risk for developing cardiomyopathy, although it doesn't happen that often. So we look specifically for ACTA1, dynamin 2, and TPM2 mutations. The cardiac involvement incidence is a little bit higher in MTM1 and RYR1. The recommendation is for screening asymptomatic patients every 2 years. And then we rely heavily on the pediatric cardiologist who specializes in neuromuscular disorders to tell us how often the patient needs to be seen once they identify a problem. Next. For respiratory involvement, I think it's important to know first of all, that all patients who have congenital myopathy are at risk for developing respiratory insufficiency. And this is because the respiratory function is directly related to muscle strength. So the weakness of the diaphragm or the intercostal muscles contributes greatly to the development of restrictive lung disease. In addition to that, this population of patients has a high incidence of bulbar dysfunction. So there's facial weakness and weakness of the muscles of the nasopharynx, which puts them at high risk for obstructive sleep apnea, even if their lung function is normal. Once the lung function drops to less than 65% of predicted, they are at high risk for sleep disordered breathing, meaning hypoventilation during sleep. There is some association between the genetic mutation and the risk of respiratory involvement. And patients with myotubular myopathy and severe pneumonia are at the highest risk for needing ventilatory support. Next. So we see these patients at least once a year. When the younger ones we see twice a year. It is highly recommended that all patients undergo spirometry at least once a year. This can be done easily in patients who are 5 years and older. Some smart 4-year-olds will follow directions to do it as well, but in the younger patients, we have other ways of monitoring lung function, such as MIPS and MEPS. In patients where there is some suspicion for paralysis of the diaphragm, you may want to do supine spirometry as well. We can do oximetry spot checks, venous bicarbonate. More often we do end-tidal CO2 in the clinic. And I think this is particularly important for patients who are already on some type of ventilatory support, such as nighttime BiPAP. They will have oximetry available at home, but when they come into clinic, it's not a bad idea to think about doing end-tidal CO2s on a regular basis so that you can recognize hypoventilation before they actually become symptomatic. So again, we do recommend sleep studies and overnight oximetry, which can be done at home. Usually the pulmonologist will do this once a year. Or if the patient is on BiPAP and is growing, they may require changes in their pressure settings. So this would trigger another sleep study. Next. So respiratory maintenance treatments have to be adapted to the specific patient. We always recommend keeping up to date with vaccinations. We want to do everything we can to prevent the patient from developing an infection. Any infection can trigger respiratory failure. So for these patients, we want to be extremely vigilant and make sure they get all their vaccinations. There can be the use of manual assisted cough. More often we use a cough assist machine. This can be helpful in preventing infections, and there are other airway clearance techniques that we use. And again, BiPAP is very commonly needed in these patients and is prescribed on the basis of their lung function and results of sleep studies. When the patient becomes acutely ill, the most important thing is to recognize this early on. And this occurs when the families are well educated to recognize symptoms before the infection becomes severe. And they can start using secretion clearance, such as cough assist at home, early use of antibiotics is usually recommended by the pulmonologist. We want to avoid using oxygen without ventilation. If the patient is hypoventilating, they need ventilation, and they may or may not need oxygen. The use of oxygen can cause respiratory failure in patients with severe weakness. Next. The orthopedic complications can include congenital hip dislocation and scoliosis. Scoliosis can occur very early in some of our patients, in early childhood or even infancy. So the management of scoliosis in this group of patients is very different from what we see in the muscular dystrophies or patients without neuromuscular disease. We rely heavily on the expertise of our pediatric orthopedic surgeons, and particularly those who have good experience with neuromuscular patients. We do encourage physical activity and exercise, but again, that has to be designed specifically for the patient, depending on the degree of their weakness and their mobility needs. We look carefully at bone health. We pay attention to the incidence of fractures and pain management. In this group of diseases, the pain is usually mechanical, meaning it's secondary to poor ergonomics or faulty seating arrangements. We do encourage standing when possible. So we use orthotics and standing frames to get patients into weight-bearing position. This can be helpful to prevent contractures as well as help with bone health. And ambulation likewise as much as possible. On the other hand, if we have a very weak 2-year-old, we want to get them into a wheelchair so that they can have independent mobility that is consistent with their developmental age. And so we have our OTs and equipment specialists involved very early, before the age of 2 years, to make this happen. For the most part, joint contractures are probably preventable if we have the right regimen and stretching and orthotics. But it's important to remember that there are certain gene mutations in which no matter what you do, you cannot prevent the development of contractures. And please remember the botulinum toxin is contraindicated in these patients because it paralyzes the nerves. Next. Scoliosis management is done, first of all, by screening at their neuromuscular clinic visit. And generally, as soon as we see evidence of scoliosis, we refer to our pediatric orthopedic surgeons, who will make recommendations, again, based on the age of the patient and the expected disease course for their mutation. The rules regarding when you do spine surgery don't necessarily apply to this population. And we may actually want to do surgery in early childhood if the curve is extremely severe and interfering with respiratory function. Historically, we have always been pretty negative about doing surgery for joint contractures in neuromuscular diseases, but I will tell you that our orthopedic surgeons are very smart, and there are new techniques available which might actually make this more feasible than in the past. And some of our patients benefit greatly in terms of pain management and cosmetic. So I no longer say no to these surgeries, and we have a conversation with the orthopedic surgeon. Congenital hip subluxation and dislocation are very common complications in these diseases. And again, have a conversation with the expert, the pediatric orthopedist, and to talk about appropriate management for a particular patient. Next. So back to swallowing and nutrition. With our regular neuromuscular clinic visits, we pay close attention to growth parameters and histories of feeding difficulty. We are generous with the use of video swallow studies, which can help evaluate the weakness in those nasopharynx muscles. And we're very quick to prescribe feeding tubes. Most of the time, nasogastric tubes are not well tolerated for more than a couple of weeks, and in older kids are particularly not well tolerated because they're socially unacceptable. In some of these diseases, we can make a prognostic guess as to what's going to happen and recommend the placement of G-tubes very early on. When the patients have severe motility problems, we want to get our GI specialists involved. And again, we have gastroenterologists who are particularly interested in neuromuscular diseases, who are a big help to us. Many of the patients have abnormalities of speech, not language, but speech. So Zuri showed you pictures of the facial deformities and the jaw deformities that result from the weakness of those muscle groups. And this interferes a great deal with the patient's ability to communicate verbally. Their speech is hypernasal and may be very soft. If they have low lung function, they have difficulty getting air across the vocal cords. And so then we want to look at alternate ways to help them with communication. Training those muscles may be helpful, but to some limited degree, depending on how weak they are. And then, of course, dental management. This requires involvement of a pediatric dentist who has experience with neuromuscular patients and who can do as much as possible without sedation and controlling the airway secretions. There is a lot that can be done to manage the jaw abnormalities, the malocclusions, and we want to avoid surgery as much as possible. And I think that's my last slide. I'll turn it over to Dr. Batley. Oh, no, I have one more slide, sorry. So the good news is that with all of this management, we have patients surviving childhood and getting into adulthood. And so now we have new problems to deal with, to talk with our patients about management during adulthood. So any adult woman with a congenital myopathy would have to be considered a high-risk pregnancy. The complications will depend on how severe restrictive lung disease is, whether there's diaphragmatic weakness or paralysis. And then, of course, many of these patients, particularly the RYR patients, are at risk for malignant hyperthermia. We've talked about feeding and speech. We have a handout for our patients that talks about malignant hyperthermia, what it is, how to prevent it and how to manage it, how to have a conversation with your anesthesiologist about this risk. And in some cases, in most cases, we recommend that patients have some kind of alert on their phone or a tag that indicates that they are at high risk for MH in case they're in an accident. So now I will turn it over to Dr. Batley.
Awesome. Thank you so much, Dr. Yannicka. That was wonderful. And it was great to review all of the advances that have come about these past few years and really the improvements we've made in caring for our patients, allowing them to live longer, healthier lives. But of course, with all of those improvements comes thirst for more. And so we are very hopeful that in the near future, we might actually have some therapies that are considered more disease modifying or targeted specifically for different kinds of myopathies that can actually stabilize function or possibly even improve function moving forward. As of right now, there are no FDA-approved treatments that are able to do this, but there are some coming in the pipeline, and so we'll discuss a few of those. I think one of the most well-known recent trials we'll go over on the next slides in a little bit more detail is an actual gene therapy or gene transfer therapy for myotubular myopathy related to MTM1. And this is called the Aspiro study. And so we'll go over that in a little bit more detail in a minute. A newer study also targeted towards myotubular myopathy is actually the repurposing of a drug that's approved for other indications. So in this case, the medication tamoxifen, which is used, interestingly enough, to treat breast cancer in many instances as an estrogen receptor modulator, but they are giving it a try in MTM as well. And then there are also some trials looking at an RYR1 receptor antagonist. It's kind of commonly known as RYCAL, and that's also been in early studies as well. And so this is just a couple of different options that may be coming towards us soon. But the most exciting thing, I think, is that there's an extensive amount of work being done kind of on the preclinical side. So that means in the lab, often in animal studies, and then on a more clinical side as well, in our preparation to actually perform these studies, we do have to do quite a bit of natural history gathering, so that way we can really map out what these disorders look like through time and what we can expect, so that way we know kind of whether these therapies that we're offering in trials are improving what we know to be the patient's natural history, so that way we can determine if they're beneficial and potentially worth full approval in clinical practice. Next slide. All right, so the Aspiro study. So this was a phase 2-3, what we call open label study. So all patients enrolled in the trial received a dose of this study medication. In this particular trial, they used a format called ascending dose, where earlier patients were given lower doses of the medication in order to determine safety. And then as time went on, they were able to escalate the dose. And so this looked at the use of a gene therapy. And so what I usually kind of describe that is the instruction manual for making the MTM1 protein packaged inside of a viral vector. In this case, they used an adeno-associated virus 8 viral vector to deliver this instruction manual to the cells. So the boys that were enrolled in this, and I say boys because a reminder, this is the X-linked condition, were less than 5 years old. They had a genetic diagnosis of myotubular myopathy with a confirmed genetic mutation. And because of the nature of this condition, all of these boys were on mechanical ventilation. And so over time, through dose escalation, they treated these patients with this investigational gene therapy, and their primary outcome that they looked at was respiratory function, so change in the number of hours that they required ventilation. Then they also looked at a whole host of other things, mostly focusing on motor function, and then of course, very important, survival, because we know that this disease can be very life-limiting. And so next slide. Right. So in the results from this trial, initially saw some really exciting benefits. Most of these patients did have a pretty significant reduction in the amount of hours that they were requiring ventilation during the day. And amazingly enough, quite a few of them were actually able to liberate from their ventilators and breathe on their own. But although these things were very exciting and very promising, this study is currently on hold because there were some safety issues noted during the course of this trial. There were several serious adverse events, including 4 deaths, unfortunately. One that occurred in that early low dose group, and then 3 in the high dose group. And these patients all developed cholestatic liver failure and passed from this. And the exact cause is not entirely known. We do know probably a lot more clearly now than we did maybe back then about the nature of the liver impairment that we can see in myotubular myopathy. And so it's thought that perhaps these patients were already predisposed to liver disease and then receiving a gene therapy medication, which we know delivers a massive dose of viral vector directly to the liver, that the combination of these two things was what ultimately triggered them to go into liver failure. However, it is worth noting that there were similar liver failure deaths even seen in natural history. And so there is a lot of question about whether these patients passed simply, because of the combination, or whether that might have been a feature of their MTM as well. And so that's still not clear. This trial is still on hold as this is being looked at. Next slide. And then just briefly on the tamoxifen trial that is starting up. So this is a phase 1/2 randomized double-blind trial. So what that means is that some of these patients will receive the tamoxifen, some will receive a placebo drug, and then they'll kind of cross over so that those who receive drug get placebo and vice versa. This is again looking at boys with X-linked myotubular myopathy, and they have to be more than 6 months of age. The primary outcomes in this study are looking mostly at motor function, and then some of the secondary outcome measures will look at pulmonary function and breathing as well. And so this study is currently ongoing with no data yet, but the preclinical studies did show some really interesting benefits and perhaps improving motor function and survival. So we'll be looking forward to results from this. Next slide. And then as I touched upon a little bit earlier, one of the most important things that we can do as we prepare for the kind of progression of these preclinical trials to a kind of a translational model where we're able to bring them to human patients is to really understand the natural history of these disorders and what they look like. I think that the MTM study was a perfect example of that. Being able to go back to compare with what we know about natural history to really understand the liver disease is going to be really important. And so this is an example right here of a natural history study that's getting ready to kick off that we happen to know quite a bit about because we'll be a site. And this is looking to investigate the natural history of Nemelin myopathy, specifically those with NEB and ACTA1 related Nemelin myopathy. And it will be a series of clinical assessments as well as secondary information from things like echocardiograms, potential biomarker assessment with blood work, respiratory function, and then looking at some different imaging modalities as well. So the whole goal being to really understand as much as we can about these disorders so that way we're able to kind of contribute to moving forward on meaningful disease modifying therapies. Next slide. And so, of course, in addition to MDA being an awesome resource, there are some other specific disease state organizations that we have either worked with or heard good things about from families and who are at the forefront of advocacy as well as pushing forward research. So if you know anyone affected by any of the conditions listed here, being able to pass on these reliable resources is really important.